Hello, everyone, and thank you for tuning in to Banner Health's Making the Rounds podcast, where each month medical professionals have conversations around trending medical topics. My name is Caitlin. I'll be your host this afternoon, and today is a very special day because it's our very first podcast.
Yes, definitely.
I have the pleasure of kicking off this series with two OBGYN specialists located in Tucson, Arizona. Dr. Rachel Darche, Assistant Professor of Obstetrics and Gynecology at the University of Arizona, and the Associate Program Director for the Obstetrics and Gynecology Residency Program at Banner University Medical Center, Tucson. And we also have with us Dr. Ilana Addis, Associate Professor of Obstetrics and Gynecology at the University of Arizona and the Division Head of Obstetrics and Gynecology at Banner University Medical Center, Tucson. How are you both doing this afternoon?
Doing great.
Same. I'm doing fabulous, and thanks so much for having us, Caitlin.
Wonderful. Thank you for taking the time to be with me today. So we have two different topics outlined for this afternoon, and the first is around this clouded conversation of pregnancy, breastfeeding, and the COVID-19 vaccine. You know, as a consumer, I feel like the information has gone back and forth around the risks, benefits, and overall recommendation for pregnant mothers and breastfeeding mothers to receive the vaccine. A little bit of background for our listeners. So back in August, the Pfizer vaccine was approved for adults in the United States. And with that, the CDC shared data around miscarriage statistics of mothers who received the vaccine early in their pregnancy. Through that data, they did not find an increased risk for mothers who received an mRNA COVID-19 vaccine before 20 weeks of pregnancy. So with that, let's get the conversation going.
We both agree, Rachel and I, vaccine is very safe in pregnant women, both women who are thinking about getting pregnant, those that are pregnant, and in lactating women. All our specialty organizations have supported that, and so that's the OBGYN organization, and then importantly, the Society for Maternal Fetal Medicine, which deals in high-risk pregnancy, and also the Society for Reproductive Medicine, which deals in infertility. They really have all said, after looking at the data, that there's no evidence of a vaccine link to infertility. The vaccine doesn't alter any of the cellular functions in the body, and that it really is very safe in all sorts of pregnant women.
Yes. Totally agree with all that Ilana said. And, you know, in terms of what I'm hearing from patients, because I see both preconception and non-currently pregnant patients, and then I also do see pregnant patients in my practice, I hear sort of the whole spectrum of patient concerns when it comes to vaccines in all sorts of vaccines in terms of becoming pregnant and then during pregnancy and during breastfeeding. So this vaccine really is no different from the others in terms of patient concerns. The only real difference is that it's newer. And so I think a lot of patients were really hoping to hear some data and see some data before they made what they would consider to be an informed decision. And we're very fortunate now as providers because we have data that has come out and we're able to counsel our patients a little bit more specifically about their concerns and about what to expect. You know, when it comes to fertility, we have evidence now that there's definitely no impact on fertility, on becoming pregnant for patients who have become fully vaccinated. And in fact, it is very much recommended that any patient considering pregnancy in the future be vaccinated. Back in June, I guess it was, a great article came out in the New England Journal that went over the sort of preliminary group of people who had enrolled themselves in the CDC's V-Safe vaccine registry, and the paper included over 35,000 pregnant people who had received the vaccine and self-reported on side effects and on pregnancy outcomes. Once that article came out, that really gave us a lot of good talking points to discuss with our patients. And importantly, the article confirmed what we would expect based on the science and the mechanism of action of the vaccines, that they are very safe in pregnancy. There was no difference in any of the adverse pregnancy outcomes that were examined, which included things like miscarriage, preterm birth, small for gestational age, any congenital anomalies, neonatal deaths, etc. And then I thought also interestingly, comparing the patients who were pregnant to non-pregnant, when they were vaccinated, the pregnant patients reported slightly more pain at the injection site, which overall, of course, we would consider a very minor vaccine side effect and a common one. They reported fewer other side effects from the vaccine, so things like headaches, muscle aches, chills, fever, things like that. So, I think when patients are coming to me, that's another concern that they have is I don't want to feel sick after I get this vaccine when I'm pregnant, and I don't want to have to take any medicines during pregnancy, and I don't want to, of course, I don't want to harm my baby. That's the other big one that we hear is just real concern around harming the baby. We know that the best way to protect one's baby is to be vaccinated. The robust antibody response that's by the immune system, actually those antibodies transfer across the placenta, are able to help protect the baby after the baby's born. Currently, none of the vaccines are approved for infants. I expect in the next round of studies and of the data that's coming out that they're going to be looking at the 6-month and above group of infants and children when it comes to the safety profile for vaccination in that age group. But for those first 6 months of life, just like with so many other vaccines, they're not approved in infants of that age. And so, moving forward, really the best thing that a pregnant person can do to protect their newborn baby is to be vaccinated themselves.
Rachel, what about breastfeeding? Will that have a positive effect on the baby as well?
Yes, great question. I think not a lot of patients realize or are thinking in that people who are breastfeeding who have been vaccinated are continuing to pass the antibodies through the breast milk to their babies. And I couldn't even believe this, but a couple of my patients have shared with me that there is quite a black market going currently for breast milk for sale on Craigslist, Facebook Marketplace, etc., for patients who are producing breast milk, who are lactating, who have been vaccinated, because other people who are either unable to breastfeed for some reason, have chosen not to breastfeed their own babies, but want that robust immune protection breast milk for their own children. They are trying to buy it up through the back channels online. Like everything we see when it comes to health and pregnancy too, there's two ends of the spectrum. So we certainly also have patients who very much want to be vaccinated, want their children to be vaccinated. And some of them are out there hawking their their breast milk or looking for people who are selling their breast milk just to try to protect their babies.
That's amazing. I know we both work on labor and delivery as well, delivering pregnant patients, and I've just been stunned, especially in this most recent wave of the Delta variant, the negative effects that we've seen of pregnant women coming in who also have COVID. It's been really distressing. We've certainly seen, I know both of us have seen quite a few patients in the ICU. Some have had to be intubated for a very long time, and it makes for a very difficult pregnancy. There's also a bit of, actually quite a bit of data to show that some of the negative things that can happen in pregnancy are increased when a pregnant woman does get COVID-19, including preterm labor, preeclampsia, all those kinds of things. And so that's really a big reason that we are encouraging all of our patients to get vaccinated.
Yes, absolutely. That's a great point, Ilana. And the other thing is, with this more recent Delta variant and this newer wave that we're dealing with, it's really changed our conversation with our patients because most pregnant people are young and healthy. And so I think with the original wave of COVID and over the past year or so, I think a lot of them have felt like they're so unlikely to either be infected or to have severe illness that they just didn't want to really involve any uncertainty when it came to getting the vaccine. But now with the Delta variant, we're seeing so many young, healthy people hospitalized and in the intensive care unit with the Delta variant that's really changed the conversation, because people who thought that they weren't going to be severely affected in the original round of things are certainly being severely affected now. So it's never too late, but the sooner they can do it, the better in terms of getting fully vaccinated. We are just totally heartbroken every time we admit a pregnant person to the hospital with COVID infection or to the ICU. And some of these people are so severely ill that we have to make very difficult decisions with them or with their family if they're unable to make their own decisions at that point about delivering a very preterm baby in order to get the best outcome for the baby if the mom is really doing poorly. So we've seen it all in the hospital at this point, and now we have this great reassuring data that the vaccine is safe, and which is what we would have expected. So please get your vaccines, everybody. And I would say too, for any of the non-OBGYN physicians out there who are feeling uncomfortable or unsure about how to counsel their patients who are planning pregnancy or who are pregnant, we've said it a couple times already, we'll say it again, it is safe, it is recommended by all of our pregnancy-related and OBGYN-related national societies. And if there's any hesitation, just feel free to get in touch with us as OBGYNs or to send those patients to us for those conversations.
And you can also find a lot of really good information for providers and patients on all of those national sites. They're really very good sources for physicians who have questions, and also you can find quite a bit of patient information as well.
There's so much valuable information available to patients and providers, and I think it's so important to have those honest conversations with one another about hesitations of the vaccine, and now they can look to these resources to help guide that conversation. So thank you both for sharing that. I'm going to transition us into a different topic around urinary incontinence, which may be a little weird and uncomfortable, but it is a very common problem amongst women of all ages, specifically between 15 and 64 years old and even older than that. But Dr. Addis, correct me, urinary incontinence is more than having a little leakage when you sneeze, right?
Yeah, for sure. Urinary incontinence is not a weird topic because actually lots of women have this problem, and often women think that they are the only person to have this problem with leaking and are worried about telling their doctors about it. Sometimes women think it's just sort of a natural part of aging. Sometimes women are embarrassed that they are having to wear pads or other incontinence things in order to stay dry during the day, but it's a huge problem. It's a huge problem for women of all ages, as you said. There's lots of things that can cause problems with urinary incontinence. The biggest thing that causes incontinence in women, unfortunately, is just being pregnant, and even more so having a normal vaginal delivery. With every vaginal delivery, as anyone who's had a delivery would know, there's some stretching of the pelvic floor. If you can imagine it, every time a woman has a baby, she's sort of pushing something the size of a volleyball out through her vagina. And so that can certainly cause some damage in the short term, and women are definitely also seeing it in the long term, not just with incontinence, but also with pelvic organ prolapse. So delivery is certainly a problem, but there's lots of other things that can cause incontinence. Being chronically constipated can lead to some problems with incontinence, certainly, as well as being overweight or obese. We have some very good data that shows that just with a patient just losing 10% of her body weight, she can improve her incontinence symptoms significantly. We also see it, of course, in women who have some various muscular, collagen, or nerve disorders, things like multiple sclerosis and Parkinson's disease. So there's just so many things that can cause incontinence, and there's a few different kinds of incontinence. There's one that you mentioned, Caitlin, which is the stress incontinence. That's the one where you leak when you cough and when you sneeze. It can sometimes only happen maybe when your bladder is full. Some women, even young women, notice it only when they're doing high impact exercise like running or box jump. Some women notice it more frequently, not just with cough and sneeze, but even with bending over and movement or with lifting heavy things. So that is stress incontinence. The other kind of incontinence is one that can be even more bothersome because it can come suddenly, and that's called urgency incontinence. That's that feeling you get when you have a sudden urge to go to the bathroom, and then you have to run to make it to the bathroom and sometimes leak before you make it there. Women will describe the urgency and the running. They'll also describe having to go to the bathroom with a lot of frequency, and it can become very bothersome. That's the kind of incontinence that often keeps women from leaving their homes because they're worried that they won't be able to find a bathroom in time. It's a really big problem, can cause not just sort of for health-wise, but can cause social isolation and depression and other things like that. The other really big problem with urinary incontinence is that just for our society, it costs a lot of money, where women are seeing a lot of doctors for this. They're buying a lot of hygiene products, but also we find that urinary incontinence is one of the bigger diagnoses that leads to nursing home and nursing facility admits. So it really costs us a lot. It's something that is really important to recognize and to be treated. Now, I know I certainly have a specialty in incontinence, and so I see quite a few patients who do have this problem. But Rachel, do you ever see patients who are complaining of urinary incontinence?
Yes, I most certainly do. And sort of as Caitlin said, I see the full spectrum from younger women all the way through women in menopause and beyond, all of whom are reporting the same symptoms. It doesn't quite matter. I mean, I definitely see more menopausal women complaining of incontinence than younger women. But as you mentioned before, pregnancy and the postpartum period are a very high risk time for urinary leakage. And so much of that just has to do with the size of the uterus and the weight of the uterus throughout the pregnancy, putting extra pressure on the pelvic floor muscles, and that weight and that pressure overwhelming the musculature that would normally prevent leakage or keep a woman dry. So, when it comes to pregnancy and postpartum, I generally am talking to patients about doing some at-home exercises, just like, what we've all heard of, the Kegel exercises and pelvic floor strengthening exercises. But something else that can be really helpful that most of my patients are completely unaware of is a specialized form of physical therapy called pelvic floor physical therapy. And just like you would, go to a physical therapist for back pain, you can also go to a physical therapist who has a special area of focus that is the musculature of the pelvic floor. And, helping to train those muscles and retrain those muscles and strengthen them can really make a huge impact in terms of lifestyle and in terms of symptom improvement. So I have lots of patients with great success with that type of treatment, especially the postpartum set of patients. I always talk to my patients about sort of the spectrum of options from doing nothing, because really very rarely is this a medical problem that requires treatment. It's more of, quality of life type of problem, through doing exercises at home or with a physical therapist. And then the options for sort of non-surgical inserts, which include things like over-the-counter inserts. There's, certain products that go inside the vagina and sort of expand or have some space occupying capacity, not dissimilar to a tampon, that Ilana, you I'm sure are aware of. Caitlin, maybe not so much at this point, but these products do exist, and they're meant for patients to be able to self-insert and use sort of as needed, either throughout the day or just during exercise or just during whatever part of their life they're having these bothersome symptoms. And then there's things that can be done in the office. We can fit patients for pessaries, which are also vaginal inserts, and those can be taken in and out and cleaned on their own at home as needed. Or for some of our elderly patients who are unable to remove them and replace them on their own just due to some mobility constraints, they can come into the office every couple months for us to remove and clean and replace them. And then, when I'm a general OBGYN, and some general OBGYNs do some surgical procedures related to incontinence, but I don't. So when I get to that point in things with my patients, or for patients who want to talk about surgery right from the get-go, I refer them right along to a specialist like you, Ilana. What would you generally talk to a patient about in terms of their surgical options?
Thank you. Thank you for all those referrals. And you definitely hit the high points of the conservative therapy that I almost always recommend before surgery. If a patient is specifically the pelvic floor physical therapy, women will often tell me that they've been doing their Kegel exercises, but at home on their own. But working with a physical therapist really helps women identify those pelvic floor muscles and make sure that she's doing her Kegel correctly. Certainly in the younger women, I am recommending those over-the-counter devices, as well as the pessaries that are called incontinence dishes to put in and out if they're just having situational incontinence. The surgery that we generally do is called a mid-urethral sling, and that's just a very small outpatient surgery. It takes about 15 minutes under anesthesia, and a strip of synthetic mesh is placed right underneath in the vagina, right underneath the urethra. And usually that sling comes out, the ends of that sling come out in two holes in the lower, right above the pubic bone in the abdomen, or in the inner thigh. The slings are really special. They're called tension-free. What that means is the mesh itself is a little bit sticky, like Velcro, and so we don't need to sew it in. So there's not a lot of suture or anything else in the vagina or in the area. Now, I know that lots of people have heard about the problems with vaginal mesh, and there's certainly been, for years, been lots of ads on TV about their vaginal mesh complications, but this sling is not actually what they're talking about. The sling is a very small amount of vaginal vagina, and in fact, we've had really very few problems with placing it. The other thing that's great about it is it's outpatient. People go home the same day, they have minimal complications, and it's very effective. So in a woman who is having stress incontinence, leaking when she coughs and sneezes, placing a sling can really be life-changing. We certainly also have treatments for urgency incontinence as well. Unfortunately, there isn't a really magical surgical procedure for that problem. We do often, again, start with physical therapy for the urgent incontinence, and then we'll try medication. We have various medications. Some of them, unfortunately, have side effects that preclude us using them in everyone, but it's always a good place to start. And then we have a lot of non-surgical but slightly interventional treatments that we can do for this problem. The least invasive one is something called posterior tibial nerve stimulation. That's where we do some stimulation of a nerve that sort of weirdly comes down around your ankle. And so we put electrical stimulation on your ankle, and for that nerve feeds back to the same nerves that go to the bladder, and it can be very effective for urgency problems that women are having. And it's just a few visits with nurse practitioner and putting the device on for half an hour a visit. And so it's a really good options. Some of the other things we do are a little more work. One thing that I have been doing more and more is Botox in the bladder. That's done through a cystoscope, and we inject Botox into the wall of the bladder. The Botox works pretty much in the same way that it works when people get it injected in their forehead, and what it does is it paralyzes the muscles of the bladder, and so it makes the muscles of the bladder less twitchy. and has been shown to be incredibly effective for this problem. So those are a few of the things that we can do beyond medication for urgency, and certainly surgery for the stress incontinence is a great option if the conservative therapies have failed for that.
Yeah, that's so awesome that there's so many options, really, truly, because I can't tell you how many patients I see who have suffered from urinary leakage for so long. And, their mom tells them that it's normal and it's expected and it's just part of aging. And I think that it can be such a life changer for people. So just having these conversations, all of a sudden they have hope that they can lead a normal life again. And they and I are so grateful for specialists like yourself, Ilana. Thank you for doing that work, that maybe non-glamorous work.
Yeah, maybe. And I definitely encourage, I've had many patients come who have told me that they've seen many doctors and no one has even asked them if they leak urine, and so they've been afraid to tell. So any doctor, I think sometimes doctors are, especially outside of OBGYN, don't want to ask because they don't know what to do about it. But I encourage, especially primary care doctors, to ask all of their patients about urinary incontinence and just know that there are people that are able to manage that problem if your patient tells you about it. Because I would imagine that there's lots of patients that just aren't talking about it because they're just a little bit embarrassed, because can be an embarrassing problem.
And who knew that Botox could help? There's so many uses for Botox these days.
I can't wait to see. Yeah, I can't wait to see what's next for Botox. That is just such a miracle drug.
Yes, I know. We love it. We love it in the bladder. So yeah, it's great.
A few years ago, I actually went to physical therapy for pelvic floor dysfunction, and it was such a breath of fresh air to have someone there specialized in the field who I could talk to openly about the pain I was feeling, and they could really pinpoint as to what was causing it. And I just think that's so important. Down in Tucson, we are developing a Southern Arizona pelvic floor center too, which is all around this specialty.
Yes, we're really excited about the pelvic floor center that we're developing. There is really nothing like that in Southern Arizona. It's going to be very exciting. It's going to include gynecologists. It will have urologists and colorectal surgeons. And also in the same physical place, we will have all of the ancillary services like the physical therapy that you were talking about, but also we'll be able to do all the imaging that we need to do for a wide variety of pelvic floor problems. This is something that I have been trying to develop for many years, and I've had very recently a wonderful partnership with our Banner leadership to really get this off the ground. I really look forward to that becoming a reality with all of my gynecology, urology, colorectal colleagues. We have all been working very hard to make this something that will really be an incredible service to women in Southern Arizona, and really women beyond, who are not finding the care that they need. And so we're really looking forward to that.
I'm really looking forward to it too. That's such a great collaborative space where patients can get a full breadth of care in all one building. Well, I'm happy to say, ladies, that we hosted our very first podcast, and I learned a ton from this conversation, and I hope our listeners did too.
Thank you so much for having us. This was really fun.
Yeah, thanks a lot, Caitlin.
Thank you both. And to our listeners, you can learn more about Dr. Darche and Dr. Addis on Banner Health's Find a Doctor platform at www.bannerhealth.com/doctors. And don't forget to join us next month, where we talk with 2 behavioral health specialists around the stigma of seeking mental health care. Thanks, everyone.
Thank you.